The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, here with another edition of The Genuine Article, and I'm talking to Chris O'Connor, who's professor of medicine at Duke University and the head of the Duke Heart Center. And Chris is a heart failure expert, well known, and has just recently completed a paper that will appear in JACC that deals with the important topic of risk stratifying patients with acute decompensated heart failure for subsequent events. So Chris, I guess there's been an enormous amount of attention focused on the incidence of rehospitalization and or other events in patients who are hospitalized for heart failure. I take it your study was directed to try to identify the patients at highest risk.
Yes, it was, Dr. DeMaria. We looked at the ESCAPE database. This was a clinical trial that studied advanced heart failure patients, and it was a trial testing whether the Swan-Ganz catheter, the right heart cath, was useful in guiding therapy, and the results of that trial was neutral. But this analysis really focused on the really detailed collection of information during the hospitalization of these 423 patients and see if we could predict mortality at 6 months, because they had such a high event rate. And we were able to identify some important risk factors.
But not surprising risk factors, Chris. I mean, most of these were predictable or had been shown in other studies, but you put them together into a risk score. Yes,
and I think that's the important component of this paper is clinicians need some help at the time of discharge in understanding who is at the highest risk, who is going to need heightened surveillance, who should we augment the pharmacotherapy or even consider device therapies before they go home. And putting these simplified parameters into a risk score, we think we can triage the risk importantly over a broad spectrum.
Well, just run through for us, if you will, the risk factors that you identified.
Well, what we found, Dr. Mary, is that when you looked at patients who had advanced heart failure and were stabilized enough to start thinking about going home, there was a number of characteristics, simplified ones, that one can ascertain during the hospitalization that can be helpful. To no surprise, the brain natriuretic peptide value was an important one, as were parameters of renal function, particularly the BUN in our analysis. We also found that whether an interceding event, such as CPR, mechanical ventilation, occurred in the hospital was something that really heightened the risk. And other parameters that were important were characteristics such as 6-minute walk test and the serum sodium value, for example. And so these combined, in addition to other characteristics such as age, combined into a score that allowed the clinician to simply gauge the risk from low at 5% or high greater than 90% at 6 months.
And that was really impressive. There's no question that assigning even 1 point for most of these parameters you talked about, I think the inability to take beta blockers was another one, but assigning 1 point for each one of those and a few more for just a couple of them led you to identify patients with very low risk and extremely high risk of 90%. So that the reviewers and the editors both feel that this is an important step forward, and hopefully, as you say, by risk stratifying patients in this way, we can take some action to reduce rehospitalization and death. Thanks a million for being with us, Chris.
Thank you, Dr. DeMaria.
The Genuine Article. Discussion and commentary based on articles from JACC.